Well, good morning, everyone. We are continuing with our low barrier to care month of high rounds, joined with the CFAR Ending the HIV Epidemic group. I'm just going to turn it right over to the wonderful Dr. Jessica Montoya to talk about today's today's conference. And I think Marvin will pop up the CME in the chat in a little bit, the CME code.
Yes, thank you, Jill. So I am a assistant professor in the Department of Psychiatry at UCSD. And on behalf of the San Diego CFAR Ending the HIV Epidemic Working Group, as well as the Low Barrier Care Strategy Working Group, we are hosting today's session on low barrier strategies ending the HIV epidemic with a focus on mental health. Today we have two wonderful presenters, Drs. Hussen and Meyer, whose talks will focus specifically on mental health. So first up, we have Dr. Hussen, who is an infectious disease physician and public health researcher at Emory University with a primary appointment in the Department of Global Health at the Rollins School of Public Health and a secondary appointment in the School of Medicine, the Department of Medicine, Division of Infectious Diseases. Dr. Hussen's interests focus on HIV among adolescents and young adults. More specifically, she conducts research with young, Black, gay, bisexual, and other men who have sex with men, with the goal of improving HIV care outcomes and general well-being in the population. To this end, current projects include community-based intervention development studies, mixed methods exploration of young men's conceptualizations of mental health service utilization, and clinic-based implementation science projects designed to bolster mental health in this population. I look forward to hearing from you today, Dr. And you may take it away.
Thank you so much. I appreciate the invitation and nice to see a couple of familiar faces and names out there as well as new connections too. So I'm going to talk a little bit today about a project I've been working on called CHIMES. The disclaimer from the beginning is going to be that it's a whole lot of, we still haven't figured out how to do this. So as I think many of these implementation science projects can be. And I made too many slides, but I'm going to try to go quickly through them so we have time to discuss. I don't have any disclosures. Okay, so as background, I don't think that it's any news to you guys, but just I will quickly mention, of course, that young Black, gay, bisexual, and other men who have sex with men experience disproportionately high rates of HIV infection, that those who are living with HIV in this population are less likely compared to other demographic groups to remain engaged in care due to multi-level barriers that are faced. And as in all populations, the depression and mental health problems negatively affect medication adherence, retention, and care viral suppression. So as was mentioned in Jessica's kind introduction, I'm an ID doctor. I take care of a lot of patients in this group. And really what we want to know is how can we help them to stay in care? How can we help with these issues that are so well documented at this point? So theoretically, if we know that rates of depression, anxiety, trauma are high in this population, one would think that engaging folks in mental health care should be a natural way to improve. And we know, that also that mental health impacts HIV outcomes. It would make sense that engaging young men in mental health care should help with the HIV outcomes as well. And we know, and it's been kind of postulated by a lot of different people, that integrating mental health and HIV care is proposed as a structural intervention that could decrease disparities, improve care engagement on both the HIV and mental health care side. And for those of us that work in Ryan White funded HIV care centers, like where I see patients, that this is supposed to be a feature of what we provide. And of course, everywhere is a little bit different, but it's something that, Ryan White provides funds for, to have mental health care that's delivered with HIV care. However, from my clinical practice, and then we also looked at this more systematically, kind of looking at patients in our clinic, and this was focused specifically on 18 to 29-year-old young Black, gay, and bisexual men. That just like we have drop-offs along the HIV continuum of care engagement, we also have that if we look at different stages of engaging with mental health. And so for context, where I work, we are very lucky. We have what's called the Center for Wellbeing on site, staffed with 2 MD psychiatrists, a nurse practitioner, licensed social workers, psychologists, people who can do, psychotherapy, and it's all in-house. But even with that, we saw that there's drop-offs from those where we identified mental health concerns to how many were referred, how many actually set an appointment, actually showed up for the appointment, or kept coming back to mental health care. So even though those services are physically there, there's some gaps when it comes to taking the most advantage of them, even among people who we've identified mental health concerns in. So the goal of this study that's been now ongoing for the last few years has been to develop, test, and sustainably implement the CHIMES intervention, which I'll tell you a little bit about the different components, which the overall goal is just to basically enhance mental health care uptake and hopefully ultimately HIV care engagement, with a specific focus on young Black, gay, and bisexual men. So I told you a little bit about our sites. I see Syra on the call, who is no stranger to the Pond Center. But it's one of the largest HIV clinics, to my understanding, in the country. And it's supposed to be a one-stop shop where you get mental health, you get nutrition, dental, all these different kinds of services. And the entire building is our clinic and is dedicated to people living with HIV, most of whom are uninsured, covered with Ryan White, and a fair amount of Medicaid, and some with private insurance as well. The other site that we're working with is Emory University Hospital at Midtown. So there are about 2,000 patients living with HIV, so it's a smaller population, and it's really situated within a larger non-HIV environment. So it's within an academic hospital. The clinic itself is co-located, like people have non-HIV related ID appointments as well, but they do still, get Ryan White funding and have some mental health services, not quite as much as what we have at the Pond Center, but at least 2 therapists that were there kind of part-time. And then in the last few years, there's been a psychiatrist as well. The research team, there's a lot of people, too many to name, but as with any of this kind of work, there's a research team, there's kind of the people in the clinic, and there is some overlap between them as well. So myself being a provider in the clinic, but also Jean and Amita, who have leadership roles in the 2 clinics, and working with clinic staff, with the community advisory boards of the clinics, as well as our team's youth advisory board and my study team as well. So a lot of people involved in this. So this first started with actually one of you mentioned the CFAR EHE. And so there was a EHE supplement that we had to do a 1-year study. And we looked at, we did just kind of 100 surveys with patients, 15 interviews, and then about 60 provider and staff surveys to try to get at some of these issues. And we identified several barriers to why folks might not be engaging with mental health care. At the patient level, patients might not know about the resources available. They might think they don't need them. There's, of course, stigma and cultural barriers in all cultures in the US. There's sometimes reluctance or low motivation to engage with mental health. And then, of course, the ubiquitous housing and transportation and financial issues that are problems for so many of our patients. For providers, there's competing priorities, right? You're seeing a patient who's got opportunistic infections or who doesn't have a house. It can seem weird to then bring up, maybe you should go to therapy, or you just don't get to it. Maybe we don't necessarily have training in how to communicate about mental health and mental health concerns. A lot of providers talked about wanting to build skills in diagnosing and treating common conditions, and to build confidence regarding discussing these issues. And then there's these clinic level issues like space and time for coordinated care, and availability of staff. And I will say that although we know that these clinic level issues are hugely important, those were kind of beyond the scope of what we tried to address in our intervention. So the first kind of set of solutions that we tried to incorporate at the patient level really kind of focused more on patient education and trying to dispel some of the myths. So we created a series of print materials, and this was done through an extensive process, working mostly with our youth advisory board that's comprised of young Black gay men who are living with HIV, and work with me and my research team across a bunch of projects, but they're very involved. They gave us a lot of ideas. And so these were posters. This one was a poster that was to be put up in the clinic. And you see that we kind of started doing a lot of this in 2020, 2021. So the folks in the poster are masked, but just depicting a conversation between a provider and a patient. How are you feeling? Great, I take my meds every day. How else are you feeling? I'm here for more than your HIV care. So just kind of letting folks know that they can talk to their HIV providers about mental health. This one was about kind of filling up my cup. And so just kind of situating therapy within different things that folks can do to fill up their cup, so to speak, take care of themselves. So you've got little pictures depicting listening to music or working out, and then therapy is in there as well. And then this one, depicting a text conversation between two friends, with one of them kind of disclosing that they went to therapy and that it was a good experience, acknowledging that people might be nervous about it. So these were the posters. And then we also made this brochure, kind of looking at different myths and trying to debunk them related to why barriers that people might have. Like it means you're crazy, or I can't afford it, or it's a sign of weakness, and trying to refute those. So these were kind of trifold brochures. So we again went through this extensive process, many rounds of creating them, which was really fun too. And then, presented to the community advisory boards at both clinics and the leadership, and get some more input, and a lot of rounds of input. And there were unfortunately some challenges to implementation once we got to that point. There's a huge renovation that's happened at the Ponce Clinic, which is wonderful. But once we kind of have put these things up, and then there was a lot of movement, patients were being seen on the first floor and then on the third floor. And so that kind of derailed our efforts. There was also a flood in the wintertime. The pipes froze and burst, and that was an issue. And then at Emory Midtown, I mentioned that HIV is situated within kind of non-HIV issues. And so they didn't feel comfortable putting these things in the main waiting room, but did put some of the stuff kind of in the clinic rooms where people were seen. We did survey providers about how they liked these, what they thought about them, and overall, I know there's kind of a busy slide, a lot of numbers, but you can see that most people are rating kind of 4 and 5 for acceptability, appropriateness, and feasibility of these materials. But sorry, I should say that a lot of them said that they didn't really see them around the clinic. So even though when we showed them in a survey, they said, "Oh, that looks cool, that looks fine," but they weren't really seeing them around. And in the interest of time, I'll kind of not read through these quotes, but the feedback again was mostly that they generally liked the posters, but they didn't see them that much. So then we wanted to also address kind of the perception of need from the patient level, as well as helping to nudge the providers to think about and address mental health. And so we implemented a behavioral health symptom checklist. And this was something, and I apologize because I don't remember the name of the authors who came up with this, but it was something that was published in the literature, used in an HIV clinic, and we adapted it some for our population, again, working closely with our youth advisory board. And so the goal was that every patient who came in would get a paper checklist on a clipboard, kind of check off if they were interested in talking about any of these issues with their HIV provider. And what I really like about it, and I'll show you this where it's just because it was kind of small on the other slide, these were all the things that they could check off. So you see that it's not kind of narrowly defined in terms of like DSM criteria or that kind of psychopathology per se, but highlighting that there's a lot of different things that mental health providers can help with, like setting goals, or, you know, specifically for the population that we're most interested in, things like gender expression and sexual identity and coping with discrimination and things like that too. So again, kind of went through the same type of process, working with our youth advisory board, presenting it to one clinic, presenting to the other clinic, multiple rounds of feedback, until we finally deployed it. And I gotta say, I had my hopes pretty up for this one, because it seemed feasible, and I felt like this would lead directly to increases in referrals to mental health. And you know, the first week we rolled it out, we got about almost 180 checklists back, and I should say even this is not that much, because we probably see close to 1,000 patient visits in a week, but still there was more of the distribution, and then they just really weren't getting passed out or completed. And you can see that over each week there just were fewer and fewer, and very few, sometimes none, that were getting completed. So and this is the clinic where I work, and if any of you all have tried to do, you know, implementation type projects in a clinic where you work, you probably understand the frustration and the challenges. But yeah, there's so many competing priorities, there's so many people involved and moving parts, and I, you know, we definitely tried to kind of meet with leadership on multiple occasions and talk about what's going on and troubleshoot, and we changed, you know, who was handing them out. So first they were going to get them from these you know, certain staff members, and then we changed it to be like the nurses or medical assistants who were doing the triage. But yeah, it just honestly never really quite caught on. There are, yeah, again, a lot of things. So figuring out where in the workflow it could go. There was also another initiative around social determinants of health screening that was mandated at the hospital level. So then it kind of felt like overkill to do this too. There was some staff turnover at the Emory hospital. And yeah, so there were just kind of different things that got in the way of effective implementation. Again, when we did our surveys, just pointing to acceptability, appropriateness, and feasibility, you know, the staff and providers tell us it's a good idea, but it doesn't always translate into actual implementation. And then the kind of last piece of the CHIMES intervention was, again, more at the provider level, and trying to get at these building skills and confidence around mental health care for HIV primary care providers. So we did do a couple of trainings at each of the sites. So the first one, we introduced kind of our overall initiative and gave tips about how to start the conversation about mental health. In the next one, we tried to empower primary care team members to do more with relation to mental health. We collaborated with some of the psychiatrists at each site to give a talk about kind of basics of prescribing, like SSRIs, antidepressants, things like that. And talked about, you know, screening tools and decision trees for when to involve specialists. And there were some, this was probably better implemented than the checklist for sure. I mean, still it's hard to get scheduling and attendance perfectly right. And you might get certain staff members, but you won't get all of the staff members that you would want to reach. Again, in the surveys, the providers and staff said that they liked the trainings. And overall, they give positive feedback about the intervention, but the implementation is tough. So in summary, I would say that the components of the intervention in terms of assessing acceptability and feasibility was pretty high. However, the actual implementation, which I, you know, kind of felt to my core as a provider working in one of the clinics, was suboptimal, despite a lot of efforts to engage with clinic staff and leadership. And one thing that I think I realized is that you needed more buy-in from staff at different levels. So even if the medical director tells you, hey, this is a good idea, you know, that doesn't mean that the front desk staff who has to, you know, then distribute the checklist, you know, is understanding of the initiative. And this study is still in progress. We still have to look, have yet to look at our our primary outcome data, which is about if there's been more referrals to mental health and things like that. So definitely stay tuned for that. I think I'm running up on my time, so I can stop there, thanking my team and funders, and turn it over to you guys for questions.
Thank you, Dr. Hussen. We did get a couple of questions in the chat. And so when you had that slide up where you talked about the various different levels of barriers. So we have a question about where you would place substance use on that list of barriers.
Yeah, I think that's a important point, and it's always kind of a tricky thing I've noticed just in the time that I've been doing mental health research, because it's like, oh, is substance use, like you could see it as a mental health outcome, or you can see it as something that impacts mental health. But certainly it is an issue that impacts our population and people living with HIV in general. So I do think that's important.
Thanks. And Eddie, you asked the question. So I'm happy to read it unless you want.
I can unmute. I wanted to thank you so much for that project. Really interesting, and the description of implementing a project in the clinic. I have had the experience of implementing in a Ryan White clinic, and I think your comment that you made about engaging staff at all levels is really key. But even, but even so, I've gotten busy, and then it's like, I didn't even remember to check for my own flyers or my own project. Exactly. Yeah. So I think that is like sort of when we get more into the area of implementation science, and we're really trying to embed our research into the clinic. That's one of those things that we can just talk about as sort of shared best practices and help each other figure out how to make it work, because I think it's a huge challenge. You have these great ideas, but how to keep them at the top of the list, or how to get them really embedded, I think is difficult. Yeah.
Right. Yeah, it was certainly very humbling. It was very humbling, because you think like, okay, I work there. These are my friends. These are people we like and respect each other. But there's just so many competing priorities and so many things that even as a physician there that I didn't understand about, the workflow or who supervises who, and, all these different kinds of things. So it was certainly a humbling experience.
I had a question about the checklist.
Yeah.
First, I loved the items on the checklist. What was maybe the plan for once someone actually successfully completed what to actually use the checklist for?
Yeah, so the idea was, again, we're like very spoiled in our clinic. We have right on site these, great mental health services. So the idea was, and we had this like written, in emails, and we told them is you could just look at it and say, hey, I see that you've checked this, we have these behavioral health specialists in-house. Can I refer you, for a consultation? Because we did, hear a lot, and I agree that, people felt, oh, I don't feel equipped to address all of these things personally. So we had to reassure the providers that's not the goal. The goal is just to use this to kind of initiate the conversation about engaging with, mental health specialists.
Thanks. And then Dr. Bamford has a question as well.
Yeah, I think hi, Laura. I think they're pretty much funded. I don't know if you remember me. Laura was a fellow at Penn when I was a med student or resident, I think. So nice to see you. Yeah, I think the services are pretty much funded through Ryan White. In terms of mental health, I mean, I know it can get tricky if people do have private insurance that, then they may have to pay more or something like that sometimes. But yeah, they are all Ryan White funded, so that theoretically cost shouldn't be a barrier.
Thank you so much, Sophie. I also love the idea of the checklist, and I think sometimes our patients are struggling or struggling to engage in care, and they can't really articulate why. But I think at least the checklist starts to hone in on how we can support them and that focus the scarce resources that we have. So I think that's really great. And great to see you too. Thank you so much for your great talk.
Thank you.
Any other questions from the audience?
Yeah, I'd be happy to share it. Should I just email it to Marvin or Jessica, perhaps?
Probably Marvin, since
Okay.
he has access to the listserv.
Sure, I'd be happy to.
Thank you, Sophia.
Mhm.
All right. I hope you can stay around.
Yeah.
And at the end, we can have kind of a combined Q&A discussion section. But for now, I'm going to introduce our next speaker, Dr. Erin Meyer, who is a psychiatrist specializing in caring for people with severe acute mental illness and behavioral health conditions. Dr. Meyer's focus is on helping people who are hospitalized or in the emergency department for a mental or behavioral health condition. He emphasizes a compassionate and personalized approach and is dedicated to caring for all people, particularly the underserved and vulnerable. He has experience caring for the homeless and incarcerated and has an interest in social justice and its intersection with medicine and human health. Dr. Meyer completed a combined residency in family medicine and psychiatry at UC San Diego School of Medicine. He earned his medical degree from St. Louis University School of Medicine and was awarded the Rodney Coe Distinction in Community Service 2023 AAAP Annual Meeting and Scientific Symposium. He is a member of numerous professional organizations, including the American Psychiatric Association and the American Society of Addiction Medicine. Thank you for being here today, Dr. Meyer.
Thank you for having me. I think this really works out well because the first talk was about patient barriers, clinic barriers. I'm going to talk about system barriers because if there's one thing that I disdain, it's the system. And I trained with Dr. Carlotti. He trained me. And so it's great to be back with some familiar faces and to see some names who I worked with during my time in residency. I have a deep love for the Owen Clinic and all the work that you do. And whenever I see Courtney in the hospital, I feel rejuvenated because somebody gets it. All the barriers that people who are served by the Owen team face. So thank you for inviting me. So I wanted to talk a little bit first about context, about things you already know. And then I wanted to talk about California's continuum of care for mental health, and then talk about some regulatory barriers where the system excludes people. And and then I'll prove it to you with a case sample. So should be no surprise to anybody, but HIV is associated with cognitive deficits. There's also HIV-associated neurocognitive disorders. None of this is surprising to the people in this room. Additionally, I didn't know this, but there was a charter program. So if anybody's in the charter program, that's awesome. 1599 cases studied in this charter program at UCSD, 21% reported a head injury. And the people with TBI and HIV had more neurocognitive problems than the HIV group without TBI. And alcohol use disorders were about 10% higher in the HIV with TBI group. People with HIV are 2 to 4 times more likely to use alcohol than the general population. The pool prevalence of alcohol use disorders was higher in developed countries. People with HIV are more likely to report methamphetamine use, and methamphetamine use is going up. Again, this should not be surprising to anybody in this room. Depression, anxiety is common in people with HIV. People with HIV were about 6 times, it looks like, more likely to have a schizophrenia diagnosis. People with HIV and schizophrenia had 2.64 times greater odds of mortality compared to people with schizophrenia without HIV. And the factors that were associated with higher risk of mortality, AIDS, never being on antipsychotic medication, never accessing psychiatric services, none of this should be a surprise. So that's the context. And this is the continuum. And what I put in orange are, yes, theoretically people with, so let me explain this. So there's a type of behavioral health setting. So you have urgent care clinics, you have primary care clinics, you have emergency departments, you have inpatient psychiatric hospitalizations. You can also have behavioral health diagnoses and be inpatient medically hospitalized. You can go to a crisis house, you can have an ACT team, you can go to a rehab, you can go to a skilled nursing facility, you can go to a neurobehavioral unit if you have traumatic brain injury. You can go to what's equivalent now of like the asylums before the LPS Act, these Institute for Mental Diseases, which is like a long-term locked residential. You can have a psychiatric conservatorship, an LPS conservatorship. You can have a probate conservatorship. And so what I put in orange are places that, and I put yes, where you could be seen if you have depression, whether or not you could be seen at any of these or admitted if you had schizophrenia, if you had stimulant use disorder, if you had traumatic brain injury, if you have dementia, if you have, and then you get to the more challenging things. And this is where the system falls apart. If you have combined morbidities, so a combination of mental health plus SUD, a combination of mental health plus cognitive disorders, a combination of substance use disorders plus cognitive disorders. And theoretically, if you have these combined disorders, you can show up to an urgent care clinic and primary care clinic, but oftentimes, because of the executive functioning and impulsivity and disorganization that comes with these multiple morbidities, it's not going to happen. And then you have, if you go down, the emergency department is the lowest barrier service. Correct me if I'm wrong, but the emergency department is the lowest barrier service. And that's the problem. Inpatient psychiatric hospitalization, you're excluded if you have just a substance use disorder alone, if you have traumatic brain injury alone, if you have dementia alone. Inpatient medical hospitalization, none of these you can be hospitalized for a medical hospitalization other than a traumatic brain injury. Crisis house, only if you have schizophrenia or depression, but if you have a mental health disorder plus a substance use disorder, they might say, well, I think this is more likely due to a substance use disorder, so we're going to exclude you. You can theoretically be admitted to a crisis house if you have a mental health plus cognitive disorder, but you have to participate. And we see this in residential rehabs where people with cognitive disorders are much less likely to complete the program because of their cognitive deficits. So we say like, oh, well, it's a low barrier residential rehab, but you're too cognitively impaired to actually participate and complete it. And so you elope or you leave against medical advice. And so when we call things low barrier, it also has to be appropriate and accessible to the individual on an individualized level. If you're talking about an ACT team, like it would be great to have street outreach, like an intensive case management team that's low barrier. And if you have depression or schizophrenia, that's great. But if you have mental health plus a substance use disorder, well, it could just be due to the substance use disorder, so we might not accept you. Or you're qualified because you have a mental health disorder, but now you have a cognitive disorder and you can't voluntarily engage, or it's difficult for you to engage, so you'll be discontinued from those programs. So what's designed to be low barrier becomes high barrier when you have multiple morbidities. A residential rehab could be mental health plus SUD is a problem because, well, you need to be stabilized from your mental health first, and then go to the residential rehab. So it's a crapshoot. So these yellow boxes are all crapshoots. So a mental health plus SUD, well, is it mental health first, or it's the chicken and the egg? The problem with these skilled nursing facilities and neurobehavioral units for people who may have HIV is that, well, if you can't demonstrate that you have a pre-existing mental health disorder, then you're excluded from these. And so when I talk about systems being tailored to patients, it needs to be tailored to the level of patient complexity that we're seeing. And why is this happening? Well, it's easy. It's math. So how to create a low barrier system, more beds, less regs. In San Diego, you can see the projected need for beds is about, it's going to outstrip the projected, so 85% occupancy in San Diego are hospital beds, 4,950. And in 2040, if we don't build anything more, we will outstrip our supply at 85% occupancy. Similarly, with long-term care, like SNFs, our supply has outstripped by 2020. So we're facing a crunch in acute hospital beds, in SNF beds, in residential beds. This is 2030, where we're approaching our limit if we don't add more. And this is as beds are closing throughout the last decade because of poor Medicare and Medi-Cal rates. And psychiatric beds, why do we have all these regulations? Well, we're supposed to have one psych bed for every 2,000 people, but in California, we have one psych bed for about every 6,000 people. So when we talk about low barrier is only if we have enough beds. Psych facilities has dramatically gone down over the last 20 years, if I can add right. And so one of the big things with California that was recently changed yesterday, Senate Bill 43 extended grave disability to people not with more than just a mental disorder, but people with a substance use disorder alone, because this has been a problem for people who are facing stigma because of substance use disorders. This is our California Code of Regulations, 1820.205, for determining medical necessity criteria for psychiatric inpatient hospital service admissions. So G and H are problematic for people with HIV, especially cognitive disorders, but only if you have a cognitive disorder related to or associated with delusions or depression. Substance-induced disorders, but only if it's associated with psychosis, mood, or anxiety. If you're just gravely disabled because of a substance use disorder, you're SOL. If you're just demented, you can go back to the street. And we have no system of care for people on the streets with dementia. We have very high barrier services there. This is Interqual, which determines all of our medical decision making. So Interqual allows a alcohol use disorder admission about 4 days. And after those 4 days, the hospital doesn't get paid. So people who are gravely disabled due to substance use disorders are sacrificed. And we see this all the time, where people need a higher level of care than the streets, which have a very low barrier to live on them. We see this time and time again. And when you talk about skilled nursing facilities and IMD facilities, we have regulatory high barriers. So look at letter D. So an IMD, and this extends to a skilled nursing facility, you cannot admit any person who is non-ambulatory, requires a level or levels of medical care not provided, or who is diagnosed only with a substance abuse or eating disorder. And so anybody with a body has a difficult time fitting in to the mental health system. And you see this in San Diego. So in San Diego, if you wanted to go to an IMD, the primary diagnosis, again, cannot be a substance abuse related disorder. It must not be primarily a manifestation of a developmental disorder, dementia, or traumatic brain injury. They will allow a substance abuse diagnosis as a concurrent diagnosis. And all of us know that substance abuse diagnosis, that's not the term. It's still, this is just part of the stigma that's baked into our regulatory language. And this extends, these kind of limitations extend to adult residential facilities, skilled nursing facilities, neurobehavioral units. And how does this play out? So this was a patient who I got admitted to both, because I wanted to test it out, because at the heart, I'm a troublemaker. I'm an anti-authoritarian troublemaker. And so I admitted somebody who had been hospitalized multiple times in the medical units for alcohol withdrawal. And I placed him on an involuntary hold because he was gravely disabled due to an alcohol use disorder. This is his MOCA. He didn't do very well. And this is what Blue Shield said after he was denied medical hospitalization. So we cannot accept this because we were told you needed care for your mental health problem during this hospital stay. Your alcohol withdrawal symptoms were well managed and not severe. The doctors put you on psychiatric hold to make sure that you cannot leave. And so then I admitted him to the psychiatric hospital to prove what I knew, that he would be denied. So they said reimbursement for acute services is not authorized as of 9/29/2021. They did not have a diagnosis covered by Title IX for inpatient psychiatric hospitalization. And even though he was gravely disabled and certified by a hearing officer, he still, because it was only a substance use disorder, it wasn't associated with psychosis, mood, or anxiety disorder, he was denied reimbursement to the hospital. So, and I took it one step further. So this is 12 people. These are 12 people over the course of 6 years that we ended up placing on conservatorship and needing to file with the help of the city attorney, basically suing the county to provide care for people with grave disability due to substance use disorders. These were their emergency department visits, 12 people over this period of time, 3,300 emergency department visits. Again, the emergency department is very low barrier. So low barrier, though, is not enough. But the inpatient days, 2,400, ICU days, 26. Over the course of 6 years, this group of 12 people had 700 CT scans, 932 X-rays. Their average MOCA was about 13, but with sobriety, it got to 16. And so when we talk about low barrier services, we need low barrier services along the continuum of care that's individualized to the people based on their cognitive deficits, based on their combination of morbidities, whether it's cognitive, mental health, substance use disorders. And so I appreciate your time, and I wanted to show that this is what we're dealing with in our emergency departments, and with low barrier clinics. I'm sure you also have people who are very cognitively impaired, and we're dealing in a system of scarcity, and so I appreciate every one of you who are toiling against a system of grave inadequacy. And that's all I have.
All right, thank you, Dr. Meyer. So your talk raised a lot of questions in the chat, so I'll try to do my best to get through it all. Perhaps first, Jeff Taylor, you made a comment. Are you there?
Yeah. Do you want me to read it?
Sure.
Sure. So I live in Palm Springs, and we have, as you know, an older population, but there's also a lot of substance use disorders, sexual compulsivity, PTSD from living decades with HIV, a lot of intersecting comorbidities. And they also have some kind of neurocognitive deficit. And it's really hard to kind of disentangle, if it's the chicken or the egg with that. So it gets really complicated. It's one of the biggest complaints we hear from providers. They can handle their clinical care, but the mental health piece is just a mess. Thanks.
Yeah, it's siloed. And I think if we move more towards behavioral manifestations and less towards silos of diagnoses and diagnostic systems, I think we'll move closer to like an integrated holistic care. And your point is very well taken about wanting to tease out which is which, but it's still just one person.
Thank you. Nettie made a comment that the description is triggering her of the pain to get her patients connected to the right services.
I do. I mean, you can tell from all the other comments that your talk should come with a trigger warning for anybody who works in a HIV clinic or environment clinic. I mean, it is that cycle is what we face every day because we are low barrier, right? So people come in and I have the same thing where I send them here. Nope, they're not quite right. I send them here and I know all the programs and I have so many connections and so many resources and internal, external, community connections, so many resources and they still just come back to our door because we are the low barrier door. It's extremely frustrating. I wanted to just also pick up on, I think that this is not what you meant, but you were talking about how people go to the low barrier locations, but then you said what we need is individualized care, and I think you mean care focused on what the individual needs. But one thing that happens with that terminology is that's how we get so many niche programs. This program only serves people with high needs if they have to have severe mental health disorder. This person only serves people who have minor mental health disorder. So because your patient didn't quite read the textbook to know what to say when you sent them there, the individualization, which I don't think that's what you meant with the word, but that is what is being used to create so many niches, and then people fall between all of them. They bounce down like a pinball machine. So I feel like we need to have less individualization of the programs. They need to be focused on the individual needs of the patient. But I feel like sometimes that terminology is what really gets us into a lot of difficulty in getting patients to qualify for whatever it is you're trying to get them to.
Yes, I agree. And so I'll clarify because I appreciate that. So what I meant is each individual piece in that continuum of care needs to be low barrier. But rather than a clinic be low barrier and the emergency department and an urgent mental health clinic be the only low barrier options, and so many times it's not enough, each individual piece in that continuum of care needs to be low barrier for the people who fit within it. Is that better?
Yeah, I think it is, but I just think it's difficult. Like people get funded to serve severe mental health. So then you send them the patient, they're not quite severe enough. So then they get turned away that day. And then there's another program funded for, and so like, how do we get
high barrier?
Yeah, but I mean, they're low barrier if you have severe mental health. They're just high barrier if you're anybody else. So that's where I think the issue comes is people will say we're low barrier the same way I might be low barrier if you have HIV, but if you have cancer, I'm going to turn you away. You know what I mean? Like if you are an OB patient, I'm not low barrier to you because I don't serve OB. So that's where we end up with these quote low barrier, but only low barrier if you fit into the box that they carved out. Yeah.
We need low barrier for the trimorbidities.
Yep. Exactly.
All right. I'm going to move on to the next question that we received, which is how, if at all, do you think San Diego's recent encampment ban will impact on how people experiencing these overlapping health issues?
Oh, it'll kill people. Because their case managers don't know where to find them. They won't be as easily connected to care. You could hope that this would lead to more people going to maybe the safe sleeping shelters. But Dorian, I want to say Dorian Gray, but that's just a book. Dorian Hargrove is a journalist who just published a couple days ago about the number of available shelter beds for all the people in San Diego, and it was like in the 20s. I mean, there's just not enough shelter beds. And so when you talk about, and I know that defeats like the talking points of Mayor Gloria and other county governmental leaders saying that there's shelter spaces available, but there's not. So encampment bans are very disruptive. Mm-hmm. And I would I would ask anyone to read like Margot Kuschel's works on, she's published a lot on on unhoused populations and encampments and homeless health.
Great, thank you for those names and resources. All right, Erin Wilcott had a question. I'm happy to read it unless you want to ask it yourself, Erin.
Yeah, when you were talking about SB 43 and the expansion of the criteria for gravely disabled, it made me think about CARES Court, which I've been talking about with several of my colleagues. It's launching next month, and I'm not sure who qualifies for this program, but with the idea of expanding gravely disabled to include a substance use disorder diagnosis alone, I'm curious of your thoughts on how the CARES Court may impact the system and or forcing somebody to receive treatment that doesn't want it.
Yeah, so I'll do it like very high level on CARE Act. So CARE Act does go live October 1st. It's specifically for people with psychotic diagnoses who are failing, deteriorating before people's eyes, who have not engaged in other services, and petitioners can be behavioral health people, it can be first responders, it can be county agencies, and if you meet the criteria of CARE Act, then you can either have a care agreement that is something that you work on together that's not court ordered, or a court ordered care plan, and that involves like court ordered medications that cannot be involuntarily administered, housing that may or may not be available, housing support that may or may not be available, but it works over the course of a year in an attempt to avoid a more restrictive conservatorship. And so the CARE Act is only for a small subset of people, and you can be housed or unhoused. The grave disability, it does extend to substance use disorders alone, and then also for you can be gravely disabled due to inability to provide for necessary medical care, which we see where people might be housed, but they're wasting away in their house, and it's just four walls with nothing else. And this is part of the issue with that doesn't always meet the need, like a housing first doesn't always meet the needs of a population. And it also, grave disability extends to an inability to provide for one's personal safety.
And Dr. Meyer, just as a follow-up, do you know the name of that Senate bill?
Senate Bill 43.
Okay. All right. I think a lot of the other questions were similar about the CARE Act. So I see, Tom, you have your hand raised.
Yeah, thank you. And thank you, Dr. Meyer, for joining us this morning. You talk about the emergency department being, the lowest barrier care, but of course it is also one of the most expensive. And I was struck by the last slide about those 12 users of healthcare. So sometimes people only understand things when dollars are put in front of them. Are you aware of people who've really looked at these mixed disorders and the cost of healthcare from us not really providing adequate outpatient services for them?
No.
Do you think that would make a difference then, I guess, is the question.
No comment. I would love to be optimistic, and I would love to be able to tell you that for instance, in Hillcrest, we have the 9th floor, where I say that the 9th floor in Hillcrest is where all of like the trimorbidity patients go. And the attitude of care management and probably not just care management, but is from their leadership is they would love nothing more than not to have a trauma unit at the new Hillcrest Hospital, not to have psychiatry at the new Hillcrest Hospital, because it slows down throughput. They want an average length of stay of 6 days or less, and building out a system where you're really meeting the needs of the patients with trimorbidities and extending, really looking for collaborative relationships with board and cares and skilled nursing facilities, and working with the Hospital Association of San Diego and Imperial County, and requesting that the county pay for administrative days because of an inadequate supportive care infrastructure. I haven't heard those conversations, but I would love to receive updates on them.
Dr. Meyer, I think we're going back to Senate Bill 43, and Annette had some follow-up questions.
Well, I just thought if there was time, I mean, this is a huge change. I had a gravely disabled patient that I couldn't get anywhere. He's one of the people you triggered me about earlier. So I'm just curious, since this seems to be a big deal, if you could let us know a little bit more about it and whether you think it will actually have an impact. Where will these people go if we actually do start to recognize that someone is gravely disabled, even if they don't fit into the prior definition? So I'm just curious what you think it's going to be, the impact of it. I think it sounds like it has a lot of potential, and it's exciting.
Yeah. So those 12 people who were on the last slide, the majority of them who were placed on conservatorship had comorbid or co-occurring cognitive disorders along with their substance use disorder. And so they were best served in a custodial SNF setting. But there are people who are gravely disabled due to substance use disorders who are also not as cognitively impaired or transiently cognitively impaired, and their MoCA scores improved after a prolonged period of sobriety. And when they went to open residential rehab facilities, they left within days. And so what's missing in our continuum of care is secured residential facilities. AB 1360 by, I think, Kevin McCarty, not Kevin McCarthy, but Kevin McCarty, had a secured residential rehab, but it was through criminal court. What we need are secured residential rehabs through civil court or through mental health court, in addition to custodial settings, because people who are gravely disabled from substance use disorders, they're not all similar. And we need to, support people where they're at. And so the two major areas would be people who are permanently cognitively impaired, where a residential custodial setting is appropriate, or people who can engage in a group treatment setting and then eventually step down to an open residential with a decreased risk of leaving against medical advice. But we need a much more prolonged period of sobriety than the 4 days that are allowed in a acute hospital setting and an open setting where people are just going to walk out if they're gravely disabled.
All right. Well, we're at the hour, so I want to thank Doctors Hussen and Meyer for your wonderful presentations, for stimulating such great conversation. I do want to put a plug in. On the screen here, you'll see the San Diego CFAR Low Barrier Care Working Group. So we will be continuing these discussions and hopefully pursuing funding opportunities, establishing more cross-institutional collaborations where we can tackle these low barrier strategies to care. So thank you all. And next week, we'll continue our low barrier care working group or low barrier care series. So hope you all have a wonderful day.
Thank you all.